Good afternoon and welcome to all those participating in this webinar. This is on a rather interesting topic, that of repositioning emergency contraception. Now, India is among the countries that has liberalized access to emergency contraception as per decisions taken around 2002. Method is available under Schedule K, which means it's available without a prescription from drug stores, and is also available through the government outreach program. And yet we find, when we look at the National Family Health Survey records, the last one, NFHS 5 of 2021, 19 to 21, in the one reference year, the past year, about 0.4% women, married women who were interviewed, reported using emergency contraception. On the other side, there's a study from 2010 to 12, which showed that about 10 million, 15 million doses were being consumed in a year. This is market research data. The estimate for the current year is somewhere around 30 to 35 million EC pills. So there's very large sales in the market and yet very low reported use by married women. And we acknowledge that it could be others who are using this. So we have an incongruous situation. Meanwhile, there is evidence that the emergency contraceptive pill, and I'm referring specifically to the levonorgestrel 1.5 milligram pill, could be used as an option for others in a somewhat planned manner. Now, I don't wish to talk more about it. That is an objective. That's what we are exploring today. We have a very eminent group of speakers who are coming into this issue from different angles. What we're going to do is have a first session where we are looking at the use in India, a historical perspective. We're going to look at legal issues around emergency contraception. We're going to look at some of the research evidence on the use of this method as a pericoital option. And then we're going to have a panel session that looks at evidence or some information from the ground, what women are saying about this option, what is the supply and market procurement situation, how is EC being communicating down the line, what can we do about stigma. We have kept space for questions, and then we're going to go on and see where do we go from here, where can the country go perhaps, what directions can it take. So without taking any more time, I would like to hand you over to the first session, Dr. Sunita Mittal, who is currently the director and head of the Department of Obstetrics and Gynecology at the Fortis Memorial Research Institute in Gurgaon, and was previously the professor and head of Department of Obstetrics and Gynecology at All India Institute of Medical Sciences, New Delhi, and led the WHO Collaborating Center at that institute. Will be chairing this session. Dr. Mittal has been involved with the WHO Reproductive Health Library, has been vice president of the Obstetrics and Gynecological Societies Federation, and has served in various capacities and has authored a very large number of publications. But the most important aspect of Dr. Mittal's contribution has been a lot of hard work to get emergency contraception known and popularized when it was introduced around 2005. Over to you, Dr. Mittal.
Thank you. Thank you, Dr. Sharad. It's a pleasure to be associated with this very important activity and something which is very close to my heart. You have titled this session as Emergency Contraception in India, Then and Now. You did give some statistics that reports are saying uses is very, very low according to your reports. But let me share with you, I am actively practicing, and the women whom I see, which includes both married, unmarried, in reproductive age. I will not talk about those who are menopausal, and almost 75 to 80%. If you go into the details of their history, we give a history. Yes, they have used e-pill sometime or other. Not necessarily that they're coming for abortion, or not necessarily they're coming for some this in family planning or for pregnancy related, whatever they come, but I just talk to them. I said, do you know this? And have you used it? And almost 75% commit, they have used it. And interestingly, when I was trying to introduce this in this country, this is way back in 2000, I'm talking about. Our consortium meeting was held in 2001, January. Before that, I had spoken to 4 secretaries to Government of India, health secretaries.
Seems to have lost her, Dr. Sharan.
We lost her. I think we should wait for a minute or two and at least start with the first presentation and then wait for Dr. Mittal to rejoin.
Perhaps someone can call Dr. Mittal and see if she's having long-term problems or short-term with the internet.
Yeah, I'll do that.
She's back. She's back, Dr. Sharan.
Yeah, I have the number.
She's online.
She's online.
I
Yes.
think, sorry, I think there was some. I think it has come back now. There was some network problem.
Yes, we can hear. Yeah, we are losing you and
Are you able to hear me now?
yes, we are.
Okay, I think network has come back. It's going on troubling us. So I won't waste much time, but I just wish to bring it that at that time, this concept was absolutely unknown. When I started with the WHO research on emergency,
We've again lost her.
He's coming back. May I suggest, Dr. Mittal, if you do it without video?
I'll do that and I'll switch off Wi-Fi also.
Yeah. So if we can begin with the first speaker while you we've again lost you.
Better? You can hear?
Yes, we can hear you.
Yeah, and I switched over to 4G also from Wi-Fi. So maybe it doesn't disconnect now. So at that time, even the chief of ICMR has told me, you are planning a research. How are you going to recruit women for that? Nobody knows about it. Everybody will come and ask you for abortion pill, but not EC pill. So how will you get? So at that time, what I want to bring home is at that time, it was absolutely unknown concept. People were not even aware of that they can prevent a pregnancy using it immediately. But now it's a well-known entity and it is being randomly used. If you look at the sales are enormous. But whosoever keeps data, I think women don't volunteer or they forget also that they don't use that pill or something. So we don't have, but uses is rampant. And certainly it is preventing a lot of unsafe abortions by preventing unwanted pregnancies. I won't take more time. I'll just go on to the first speaker, Dr. Srinivas Dara. He is a senior research fellow at Priyas Health Group, Pune, with a PhD in demography. He has an illustrious career and, of course, doing a lot of research and a good work in the field of youth in transition, adolescent health, and other things, and also published a very interesting book on that. So let me invite Dr. Srinivas Dara. and he's going to talk to us about historical perspective of use of emergency contraception in India. So let's hear him first. Yeah. Dr. Garrett, please. Yeah.
Thank you. Thank you very much for the kind introduction. And I'm really good afternoon
No,
to
I'm
everyone.
sorry, I couldn't actually because the network was going on and off. But I know most people here present know you. Right. Yeah, please go ahead.
Thank you. Thank you. Good afternoon, everyone. I'm really glad to be part of this meeting on a very important topic. And I think we've already started discussing a little bit of, how things were there, as ma'am said before. So what I plan to do basically is not to sort of give a lot of timeline kind of perspective, because we all know when things were approved and how, what is being approved. But what I wish to do is dwell into more research-based insights into some of the things that we just started off the webinar while discussing. How many women really know about it? What proportion of women use it? Why do they use it? What are the factors associated with the use? And a common question that many people have is, if women have easy access to EC pill, would it lead to more unprotected sex? What do healthcare providers think about it? So, some of these questions, basically to see what research level evidence we have to support some of these or answer some of these questions. Basically, my talk would be largely based on the work that we have done at Prayas. Recently, like 2-3 years back, we did one systematic review and meta-analysis of emergency contraceptive pill use in India. So largely, I'll be shaping my talk based on that report and paper. And then very recently, we did one large-scale youth in transition study among unmarried youth, and also published few papers from on resurgence of syphilis based on the clinic data that we have at Prayas. So that will be my source mostly. Getting into the first question of how many women really know about ECP. So as Dr. Sharad said in the beginning, one of the large-scale source we have is that of NFHS. And if you look at NFHS, 2005 were the things when ECPL started making entry and approval. So at that time, the knowledge was pretty low. Around 11% of the women knew about ECPL, which has gone to 48%. Still seems like a huge gap, though there is a significant progress in last 15 years. So almost like 37-38% increase. If you look at some sort of disaggregated data, has that increase been consistently across all segment? By and large, yes, but still there are certain vulnerable populations where the knowledge is still lacking. And I just took 2 examples to highlight some of this. For example, if you look at the change in knowledge in very young people, 15 to 19, that is the lowest change that you see compared to like 25 to 29 or 30 to 34, which again highlights towards how marriage-centric our sexual reproductive health services by and large are there in India. Also, you can see in the graph below, if you compare knowledge about ECPL and marital status, you will see that unmarried women, the change in knowledge is relatively lower compared to ever married women. So something that we need to look into when we are thinking about repositioning ECPLs. The second question of how many women actually use ECPL. So that's a very difficult question to answer, because we really don't have a lot of reliable data to answer this question. And when we thought of doing a systematic review and meta-analysis, that was exactly our perspective as well, that we really don't know some. When we speak to gynecologists, they say, okay, everyone almost coming to me is using EC pill, but the NFHS data says something else. So we did a systematic review, and based on the research that reported prevalence of EC pill use, we did a meta-analysis, and the meta-analysis showed that 6% of women use emergency contraceptive pill. Most of the studies were of poor quality based on the Newcastle-Ottawa scale. But there are some studies which are of good quality or good robustness. And only 4 or 5 studies have reported repeat use. And among those studies, it reported the range was from 12% to 16%. So I wouldn't call this still a very rigorous sort of evidence, but it definitely, the NFHS data of 1% or less than 1%, 0.6% seems gross underestimate to what actually might be the reality of number of women using emergency contraceptive pills. Looking at why women use emergency contraceptive pills, because that again is a very important consideration when we're thinking of repositioning EC pill. Most common reason is, condom slippage or tearing of condoms, or those who are on regular contraception and have missed their OC pills, or have miscalculated the timing of safe period. Of course, unplanned sex or unavailability of regular contraception also emerge as the important reasons for why people or why women use EC pill. Overall, recently to 2023, like November 2023, there is a paper published which used again NFHS data, but did a regression analysis to find out what are the factors which are responsible for predicting use of EC pill. And generally, we see that compared to younger population, women in the age group of 25 to 39 are more likely to use it. Women from urban area are more likely to use it. Those who have higher education or higher economic status are more likely to use it. And unlike some of the belief that women might not use it because of the religious reason, or they might feel that it is it is leading to abortion, which could be a barrier. At least the quantitative analysis did not show that religion was an important factor for use of EC pill. From the same quantitative analysis, I want to again sort of highlight some of the things to bring the attention to issues of young people. If you look at carefully the regression model, what you can see is, so there are 2 aspects. One is knowledge about emergency contraceptive pill in the second column, and the third column is ever use of emergency contraceptive pill. So if you look at young people compared to 15 to 19, which is a reference category, women in 20 to 24 have more knowledge of emergency contraceptive pills. But when it goes to use of emergency contraceptive pill, both these age groups, 15 to 19 as well as 20 to 24, there is no significant difference, which means that the use, which relatively is higher in this age group, is same in young age group of 15 to 19 as well as 20 to 24. The second important point is, when you look at current contraceptive use and use of emergency contraceptive pills or ECP, one realizes that compared to those who are not using current contraception, those who are using some contraceptive methods, either it is a regular OC pill or male condom, they are more likely to use it. So actually, probably this indicates they're using it as an emergency when the regular contraceptive has been missed or has been not not used. So that is another important finding or something to keep in mind. And again, another important thing is that there is no significant difference between never married and ever married women when it comes to use of emergency contraceptive pills. So which means we cannot miss out on a group of never married women when we talk about emergency contraceptive pills. The third question was if there is access in significant improvement in access to EC-pill, would it lead to more unprotected sex? The evidence doesn't support this sort of hypothesis. There are two papers from India. In one of the studies, both cohort studies, in one of the studies, they have supplied EC-pill to women along with information, and the other group had only received information. And they noted that the group who were given supplies of EC-pills had no significantly higher unprotected sex, as well as they had much higher rates of using EC-pills and thus possibly lesser number of unwanted pregnancy. Also, there are some global studies which do not support this stand, that if women have easy access to emergency contraceptive pill, it will not necessarily lead to more unprotected sex or coming to the another aspect which when we did systematic review, we felt it is a significant aspect in Indian context, and we must sort of address this issue, and that is the issue of attitude of healthcare providers towards emergency contraceptive pill, because use of EC-pill is considered as your failure to engage into a sexual relationship that are responsible. The judgments that gynecologists or healthcare providers, pharmacists have contribute significantly to the stigma associated with EC-pill. There are papers, I think 5 papers amongst the review that we did, which documented the beliefs of gynecologists who says that if those who are using EC-pills, they probably have risky sexual behavior, multiple sex partner, premarital sex, or also have higher sexually transmitted EC-pill. So this sort of notion of sexual promiscuity that goes into the minds of healthcare provider is a concern that we must address while addressing access to SRHR services. To dwell a little bit further on the sexual behavior and how it reflects from a young person's point of view, I will share some of the findings of the study of youth in transition that we did in Pune among unmarried adults who were 20 to 29-year-old. Total to 1,240 adults were interviewed. And basically, I won't go into detail, but this was a life course study. So we had designed a calendar, and the calendar was basically from the age 10 onwards till their current age, which plotted all their partnerships and condom use and everything, along with transition into other domains. To give a highlight of basically the people who participated in the study, majority, almost more than half of them had serious relationship, and the others had different kinds of relationship, such as casuals, friends with benefit, or exploring relationship. So basically to show that diversity. Interestingly, this similar diversity we need to keep in mind when we are looking into the sexual behaviors of young people. As you can see, around 85% of the women and 74% of the men ever had a relationship, and 49% of the women and 53% of the men ever had a vaginal sex. And also, the proportion of young people engaging into oral sex and to some extent anal sex was not insignificant. Oral sex particularly, definitely much higher than anal sex, but this is largely a heterosexual population where anal sex was also reported in significant number, and which I think also has a bearing when we reposition, when we communicate about EC pill, because it is not only about, while talking about safety in sexual relationship, we will also have to message about safety, which is not related to pregnancy as well. The median age is also, there are reports which shows that median age at sexual debuts is going down in Indian population. We had 13% of the people who were sexually active before the age of 18. This is slightly difficult figure because it's not very conventional, but basically this is since we had a longitudinal calendar data, we wanted to find out from the data statistically what are the clusters or what are the typologies of people following particular kind of relationship. And we came up with 4 typologies. The one with a prominent blue, you can see as the age progresses, the people stay in committed relationship and do not have penetrative sex. So therefore, it's a commitment, no sex kind of group. The one below that with a significant green in it, you see people largely engaging into committed, serious relationship, but also having penetrative sex. And you can also see the red on the top of that, which shows that those people are also engaging into a parallel multiple relationship kind of situation. So all these people, because they were unmarried, the frequency of sex was not very high, but sometimes because they are parallel multiple relationship, the number of partners at times could be higher in a particular period. Similarly, the other 2 clusters, you have one cluster of people who do not engage into committed relationship, who would like to have exploratory relationship and also have more parallel multiple relationship. And then another group who do not engage into a relationship for a longer period of time and engage, afterwards, like after 23, 24, that is when they start their relationship. So the reason why I thought it's important to highlight this is because we've been looking at sexual behaviors and relationships in a very cross-sectional, static manner, ignoring the dynamicity of the way relationships and sexual behaviors evolve over a period of time. Again, from a HIV point of view, interestingly, one of the recent studies shows that districts that have very higher rates of HIV are the ones where there is high literacy, late marriages, and where the socioeconomic status of the population is very higher. And also we are seeing from our data that there is some resurgence of syphilis and other sexually transmitted diseases in urban area among younger population. So the sexual behavior, the changing context of sexual behavior of younger people also needs sort of consideration while thinking about the issue.
Dr. Dara, could you wrap up, please?
Yes, this is the last slide. Some of these findings are available on our website through this report, 6 research briefs on youth in transition. And to sum up, basically, as we've seen, the knowledge about EC pill have increased, but there are still vulnerable groups such as young people or unmarried women where we need to focus. The EC pill, there are some social demographic factors that affect the uptake of EC pill. Those who are already using some contraception, either condoms or regular oral contraceptives, are more likely to use EC pill. That is something that needs to be kept in mind. And also the judgmental views of healthcare provider. And the point that I wanted to highlight was the context and diversity of relationship of unmarried people that needs to be considered during communication on EC pill. Thank you.
Thank you, Dr. Srinivas. for sharing your data. Wonderful work. Also reviewing the literature regarding emergency contraception knowledge and perceptions.
Thank you.
I think we move on to discussion in the end. So our next speaker is Ms. Anubha Rastogi. She is a lawyer with 20 years of experience, currently practicing in the courts of Mumbai. She has been engaging with issues of human rights and women's rights and their interaction with law, and especially interested in areas of reproductive justice and rights. So she's the right person to have legal issues around emergency contraception. So Ms. Anubha, please. Is she here? I cannot see her.
I'm calling her, just maybe she's not here.
Okay.
If she has dropped off, maybe we should have Dr. Festin
Maybe.
present.
Yes.
Okay. We
And then,
move on to Dr. Mario Festin till she joins us. Dr. Mario Festin is a distinguished professor at University of Philippines, Manila, College of Medicine. He serves as a vice chair for academic affairs and postgraduate studies in Department of Obs and Gynae. Also acts as an advisor in the Division of Maternal and Fetal Medicine, Sexual Health and Family Planning. And he significantly contributed to leading Philippine study group for reproductive health at the National Institute of Health of Manila. His international contributions are noteworthy, having worked at WHO in Geneva, Switzerland, where he served as coordinator, lead specialist, and medical officer on family planning. His extensive contributions to research are evident in over 70 international publications. He's recognized all over because of his numerous awards and, of course, very, very famous person. They met him. So let him talk about WHO trial on pericoital contraceptives. Dr. Mario Festin.
Thank you, my dear friend, Dr. Sunita Mittal. I think we've known each other for nearly 30 years.
Absolutely. I hope your cup is doing well.
So, I am, can you see my slides?
Yeah, we can see.
So, I'll try to make this. This is the study that we participated in WHO over 10-15 years ago. Pericoital oral contraception with levonorgestrel. So this was a prospective open-label single-arm multi-center study. So pericoital oral contraception, that means a contraceptive taken at or around the time of sexual activity. So you take a pill so that you could use it to prevent a pregnancy at the time you have sex. This will help fill a gap because sometimes women do not feel motivated to take a pill every day regularly when they have sexual encounters, especially if they don't have frequent or regular sexual encounter, coitus. Many men and women prefer oral methods compared to barrier methods. And probably overall, the dose will be less frequent compared with daily taking oral contraceptives. Women would be less likely to forget because they only take it at the time of sex and not every day, even if they're not having sex. Some women in other regions are actually using it, but they don't have any evidence or guidance. So even if efficacy is moderate, it may make a substantial impact. Previously, there were already studies using levonorgestrel 0.75 for pericoital use, mostly in Europe, and was reported as early as 1995. a Cochrane review showed that women who used 1,100 human years, there was a pregnancy rate of 5.4 pregnancies per 100 human years. So at that time, Postinor or levonorgestrel 0.75 was being promoted for postcoital use. But because they saw this, it was now relabeled for emergency contraception, and it has remained so for many years. Now they want to bring it back for pericoital use, and the recent FHI 360 study did another pericoital study, and they found that the Pearl index was 18 per 100 women years. And that was uncomfortably high because we hoped that the uh, Pearl index would be 10, would be less than 10 per 100 women years. So this paper, this research was designed as a phase 3 prospective open label single arm multi-center trial. They would have each participant would have a visit and 3 follow-up visits at 2.5, 4.5, and 6.5 months. So the duration of participation is also only 6.5 months. This was in 2011 to around 2014. So we wanted to see if this can work. The indication was contraception for women who have relatively infrequent coitus. So we wanted to look at 3 things: efficacy of the study regimen. We look for women who have sex around 1 to 6 times a month, and they will only use this as their method of contraception during the period of enrollment. We also wanted to look at safety, mostly on vaginal bleeding and on the presence of anemia. And we also wanted to evaluate acceptability. So the inclusion was fertile women, reproductive age group, who have infrequent sex, around 6 or less per month, at low risk for sexually transmitted infections, meaning they are more or less stable with one partner. They have no contraindications to progestin-only contraception. They have no contraindications to pregnancy, and they are willing to use this method as their only contraceptive for 6.5 months. The instructions were each time they have sex, you take 1 tablet, preferably before or even still after the sex act, with a window of 24 hours before or after. They're not supposed to take more than 1 tablet in any 24-hour period. If they feel that they are at risk for sexually transmitted infections, they may use condoms. So there were 4 types of analysis populations, but the ones we are most interested in will be the evaluable population, which means all those who have follow-up data. But we also have a primary evaluable population, which are all those in the evaluable population but less than 35 years old. So we have the intention to treat population and the user population, but we'll focus on the EV and the primary EV population. So how do we measure efficacy? We ascertain pregnancy by urine pregnancy test, and we measure, the indicator was Pearl index of pregnancies per 100 human years. Safety was by collecting data by using a diary, taking blood pressure and hemoglobin, and obtaining data on all certain pregnancies if they took place, and more frequencies and changes in patterns of bleeding and what has happened. Acceptability is based on questionnaire items and how many discontinued participation. There were mainly 4 sites in Thailand, in Bangkok, in Singapore, in Szeged, Hungary, which was one of the main centers in the early studies on emergency contraception more than 30, 40 years ago, and the study site in Campinas, Brazil. There was a 5th site but dropped off because of the absence of an ethical review, so Brazil gladly added on to have more participants. So the study duration was from 2012 to 2014 until we reached over 300 participants. So this is a relatively complicated chart, but we'd just like to bring you that we started with 885 who were assessed for eligibility, and we ended up with 328 evaluable population and around 208 primary evaluable population, which means those below 35. Okay, next slide. So what were the results? In the evaluable population, which means the 328, there were 10 pregnancies. In the primary evaluable population, or those less than 35, there were 9 pregnancies. What were the outcomes of these 10 pregnancies? 4 were terminated by elective abortion, 1 miscarriage, and 5 ended in live births. There were also 2 pregnancies that were noted, but these were not related to the study PIL, which means that they were already pregnant at the time of the enrollment, and 1 participant got lost to follow-up. So what were the PEARL indices? For the primary evaluable population, which means those less than 35, overall there were about 204 participants. There were 9 pregnancies, for typical use, the PEARL index was 10.3. But for perfect pill use, it was 11.1. So it's not very different. So 10 to 11.1. The evaluable population, which is the bigger group, the overall PEARL index was 7 for typical use, but for perfect use, it was 7.5. We were wondering why with perfect use, the pregnancy rate would be higher, but that was something we thought that was just the data that we saw. We found that the pregnancy, the outcome failure was the last one, the pregnancy was before 140 days. So if a woman maintained on this regimen for more than 140 days, it was already more likely that she would not get pregnant. So how about adverse events? So most of the adverse events were moderate and mild, but there were only 3 severe adverse events which we'll describe. And upon the assessment of the investigators, 42 were probably related and the rest were not. And how many of them did we require to stop using the pill because of the adverse event? Most of them continued or were asked to still continue, but only 6 or 5.9% were asked to discontinue. And what were the outcomes of the adverse events? Most of them recovered without sequelae. There were 2 who recovered with sequelae, and I'll describe what were these. And as of the last visit, some of the adverse events were still ongoing. And this was more related to some of these adverse events, which were headache, which was the most common, nausea, pain, and influenza, which probably would not be related, and active vulgaris and candidiasis. The severe adverse events all came from one site. 1 participant had cholelithiasis, and which later required a cholecystectomy. So those were 2 adverse events in 1 participant. And 1 participant was admitted with an ruptured ovarian corpus luteum cyst. That was the 3rd severe adverse event for which a laparoscopic extirpation was performed. The last pill intake was within 24 hours prior to admission, but it was judged as not related. How about safety data? Bleeding days. How long were the bleeding days? If they use 0 to 10 tablets, the mean duration of bleeding was 15.8. And if they had 11 to 15 tablets, it was 17.9 days. And more than 16 tablets over the 6-month period, it was 16.1 tablets. But so if you would take a look at it, the ranges are very similar to each other and would not really differ. And that will, because we looked at bleeding days and bleeding free days, and it just ranged from 64 to 73 for the bleeding free days. We also asked about acceptability, and the questions were, would you use it for contraception? And 95.7% said yes. And we asked this at 2.5 months and at 6.5 months. And it was 92.3 to 95.7. Would they recommend it to others? 96% at 2.5 months and said yes, and 97.7 at 6.5 months. We also asked them, did you have sex but did not use it? Most of them actually were very compliant, although 12.1% had sex but did not use it for 2.5 months, but it went down to 6.5%, 5.8% at 6.5 months. So it also shows that the longer you use it, the more compliant or used to. How about, would they want any more children ever in the future? It's half. So half said to 48.0, 2.5, and 44.6. So it's more or less balanced. So it just shows that many of them would still want a temporary method of contraception. So if we were going to look at the 10, this would be, and this is in the hierarchy of contraceptive efficacy and effectivity. It would be in the second tier, wherein it would be similar to the male condom and diaphragm. And those are also the pericoital methods, if you come to think of it. So a condom is only used when you have sex. And now, if we have this levonorgestrel 1.5, it would be in this category and would have similar effectiveness rates. So what are conclusions from the study? It showed that the use of levonorgestrel 1.5 milligrams repeatedly and pericoitally in women is a safe strategy and is generally well tolerated contraception by women. The contraceptive efficacy is higher than women who do not use contraception, so it has benefit and is comparable to women who use contraceptives coitally dependent, and that is similar to condom. And there are, of course, disadvantages of using the condom, which are not found in the use of a oral contraceptive pill like levonorgestrel 1.5. What were supposed to be the next steps after this study? We were hoping that it will be a formal comparative study with other pericoital methods like condoms or with other new products. However, there was no interest from the funding agencies to do this. They also wanted to do a follow-up of longer duration for at least a year to see if the compliance after 142 days would still continue even beyond. So we also wanted to see an actual use study wherein we wanted to, not in a controlled environment, but how women who would use this would have reports of pregnancy to see if it would increase contraceptive prevalence, and it could be used by an intended population, meaning women with infrequent sex. And we'd like to see how such women actually use, what are their patterns of use, and see what were their side effects if they really were using this, not under controlled circumstances. Because we want to get a bigger population base to comply with existing agency requirements for regulatory agencies. The thing is that this was not to replace women, this is not to replace the contraception of women who would benefit from use of continuous contraceptives. like those who prefer to use oral contraceptive pills, IUDs, etc. So the indication was really for a very select group. There were some follow-up studies which were similar, which used the same product, levonorgestrel, 1.5 milligrams. And one of these was in Kenya. And this was a 12-month prospective single-arm open-label interventional study. So this was in 2020 to 2021. You could imagine this was being done during the pandemic, which was also going on in Africa. They had 897 women. And this was mainly really to look at whether e-commerce pharmacy provision is feasible. And they said that it was feasible. And for the women who used it, it was acceptable. So it really did not look at the other important aspects of efficacy, which was be needed for regulatory agency. The other study was in Ghana, which was also a 12-month single arm it was to test whether this 1.5 milligram LNG on demand or pericoital was acceptable. This was a big study with 1,890 participants, but it was an acceptability study. So results indicated there was a demand and acceptability for a pericoital pill, and that women would want to access it through a pharmacy. So the findings of this was high levels of satisfaction, and it became they liked it in terms of use. So the later two studies, actually I was in the advisory board of this, and I could not get them to really do an efficacy study, but this was the findings for acceptability and for feasibility for access. So that is my last slide, and I'd really like to thank again Dr. Sharad for inviting me to share this information, this data, these findings with you, and we really hope that somehow, somewhere, pericoital contraception will be able to be used. Well, one thing that what this can say in terms of the use of emergency contraception is the issue of repeat use of emergency contraception, what are the effects and what are the possible efficacy issues. So that's it, and thank you very much.
Thank you, Mario.
Thank you. Thank you.
Wonderful study. Very, very interesting. Yeah. Yes. Do we have Miss Anubha here? Has she joined us?
Yes, I'm here.
Okay, so welcome, and I introduced you, and you're going to tell us about legal issues around emergency contraception. So let's first hear you, and then we can.
Sure. Can you share my presentation, Gunjan? Thanks. Right, just the next slide. Yep. I hope I'm audible. Right.
Yes, yes.
Thank you. So some of the main laws that impact the existence of the EC pills in this country. So there's, of course, the Drugs and Cosmetics Act, its rules and its regulations. And within that, something that's of extreme importance are the minutes of the Drugs Technical Advisory Board meetings, the DTAB as it's called. The next one is the Drugs and Magic Remedies Objectionable Advertisements Act, its rules and its regulations. Then I looked at some of the case laws interpreting the provisions of the law. And finally, I also looked at some of the parliamentary questions and responses to the same, and really looked at how that discourse has also changed. The next slide, please. Then some of the policy aspects, the policy regime which impacts EC pills existence, it's the creating awareness about it, its distribution. So of course, the Mission Parivar Vikas guidelines, India's Vision FP 2020, spacing in birth guidelines for ASHAs, the reference manual for injectable contraceptives, that's MPA, reference manual for RMN CHA N plus N, home delivery of contraceptives, that's condoms, OCPs, and ECPs by ASHAs at the doorstep of beneficiaries, and as it's been amended, and the ASHA update on the new family planning methods. So these are some of the policy regimes that impact EC pills. So while analyzing and coming up with a position paper, really, these were the things that one looked at. Next slide, please. Just very briefly, the historical context, of course, I mean, everyone here knows everything about the EC pills and how they were included in the family planning program, but just a very quick slide so that, we have that context. So EC pills were included in the family planning program by the MOHFW in 2002. And in 2005, they were approved for sale over the counter. At that time, there was some opposition, but the main concerns really started showing up when the permission for advertisements of EC pills were granted. There were concerns which were raised in the parliament, and therefore, on assurances in the parliament, this was placed before the DTAB. A lot of the minutes of the DTAB over that time will show the discussions that took place. And the main concern was that the advertising of the EC pill may lead to indiscriminate use of the drug, resulting in dangerous side effects. And in many cases, the contents of the advertisement may not be socially ethical. So this was, I mean, I've just put this down on one slide. There are a lot of layers into the kind of concerns that were raised, more so also from the point of view that the burden of contraception would come on the woman, and while less is was being done, or at least the perception was that less was being done to ensure that male contraceptive choices are also available, and there is conversation to use that. But like I said, I've only reduced this to one slide at this point. Next slide, please. Right. So the DTAB, when we look at their minutes from all of those times, whenever this was an agenda point, they agreed, and thankfully so, that the drug needs to continue being non-prescriptive, so therefore available over the counter. However, it should not become an alternative to protected sex, leading to unsafe sex and rise in HIV cases. And I'm quoting from some of the DTAB minutes from that time. An expert committee was set up to look at the issues of social acceptability of the advertisement. So, I pause here. The concern really was letting people know that it's available. The concern wasn't so much about it being available. So actually the furrow was raised when advertisements were permitted, and we started seeing advertisements in the public domain, advertising the availability of this option as the morning after and pill, etc. So the expert committee's mandate was to look into the social acceptability of the advertisement, the essential information required to be made available to the consumer in respect of proper use, health hazards accompanied by its unrestricted use, contraindications, and impact on vulnerable groups, especially the young adolescent groups. The expert committee consists of various people. I'm not going to repeat their designations here. You can see that. And they gave their recommendations on 15th of December 2009. The DTAB accepted the expert committee recommendations and analysis of the available minutes of the DTAB. It is clear that the advertisement of the EC pills is permitted as long as it is in compliance with the recommendations of the expert committee. So basically, some of the things that I just talked about, the advertisement of the EC pill was permitted, and the reason why this had to be permitted will be in my next slide, which I'll just come to. But just explaining this, that the fact that it's available was not a problem. The fact that it was non-prescriptive, meaning available over the counter, was not a problem. The concern, as I said, came up when we started advertising it. And so for that, the expert committee really laid down a couple of guidelines so that the information that is being shared is socially acceptable. And the manner in which the advertisement is done is not obscene in any way or concerning in any way. And the kind of information that is required about its use, about it not being an option or to regular contraception, or to replace regular contraception, and its health hazards, if any, should be included in the advertisement. As long as all of that was done, it was fine to advertise. I'll also just point out here, it's not part of my slide, but part of the report that I did for ARTH. There were 3 cases which came up, and interestingly enough, all 3 of them were in the state of Tamil Nadu, where the aspect of advertising was raised as a concern, and there were criminal cases filed against the pharmaceutical company. All of those 3 cases didn't really result in anything much, and the High Court quashed them. But it was very interesting to see that despite it being permitted, and despite it appears, at least from the reading of the case law, that the advertisement was following the guidelines that have been given. Despite all of that, there were criminal cases lodged, and people did have to either face a trial or come all the way to the High Court to get the legal case quashed. Next slide, please. Right. So the reason why we had to come in with the DTAB was because of the Drugs and Magical Remedies Objectionable Advertisements Act 1954. Section 3 of that act prohibits the publication of any ad referring to any drug which suggests or is calculated to lead to the use of that drug for the procurement of miscarriage in women, or prevention of conception in women, the correction of menstrual disorder in women. So basically, this law prohibits the ad of any such drug which does any of the 3 or promises to do any of the 3. The exception is any condition which requires timely treatment and consultation with an RMP, or after consultation with the DTAB constituted under the Drugs and Cosmetics Act. However, and again, the advertisement should be in line with the provisions of this law, that is the Drugs and Magic Remedies Objectionable Advertisements Act, and the DTAB advisories. So as long as you're within the framework that this law and the DNC Act and the DTAB advisories have set out, you can advertise any of these drugs, which can either be used for procurement of miscarriage, prevention of conception, or correction of menstrual disorder. Next slide. Right. So like I said, that the genesis of all of this was really because there were a lot of Parliament questions. I looked at the Parliament questions beginning from 2001 and stopped at 2021 when I put this together. But just the analysis was that the movement of the questions asked in the Parliament on the EC pills show the changing context of the discourse. You know, from 2001, when the questions were around the inclusion of the EC in the National Family Welfare Program, to 2009, when the concerns about the easy availability of the pill was questioned, right around the time when advertisements were permitted. And then we come to 2021, when questions are more towards population control, and the response from the government is one structured around choice, and questioning coercion and the changing statistics. So one can, just by looking at the Parliament questions on the issue, one can really track the movement of the issue, the pulse, the change in the manner in which something so specific as an EC pill has been viewed by the lawmakers. Next slide, please. And this is my last slide, and just to close, and before I get into that, I didn't really want to include a lot of the policy work, because this has been part of the government setup for a long time, and like some of the policy regime documents that I listed initially, it has become slightly more open in a sense that EC pills are now available. Ashas are mandated to talk about it. But as far as the legal regime is concerned, one can be very sure that the legal regime around emergency contraceptive pills is straightforward and clear. The pill is available over the counter, does not require prescription or any other hurdles which may result in the loss of privacy for the person accessing the pills. When I sort of compare it with the availability and the kind of information that one has to share when one needs to buy, say, a combi pack for for medical abortion. This, in fact, is just in terms of accessing an EC pill, it's much simpler, and you don't have to reveal your identity at any stage. So if you pay in cash, then that's it. Like, there's no trail at all. So in that sense, the legal regime for the EC pills is quite clear. But what happened was the advertisements of the EC pills being permitted by carving out an exception to the Drugs and Magical Remedies Act. There was an uproar created by mainstream advertising of the drug and consequent questions in the parliament, which resulted in creating a chilling effect on the messaging that the EC pills are available and are available in variety. Like, there are different brands available, different kinds available, etc. So it's amazing how the existence of a choice, made much simpler. The law really doesn't stop you, but the fact that it's available, the advertisement for that created a concern, and that's where we it sort of had a chilling effect, and people started believing that it's it's not correct, or it's illegal, or you're not supposed to keep it, etc. The fact that distribution of EC pills, and thank you for that comment, is part of the mandate of the ASHA demonstrates that the government is clear that this needs to be part of the choice that is available to women and couples while deciding on their method of contraception. So it's very clear that at that last level itself, the government wants that at least, of course, the language almost always is targeted towards women and couples, that that this exists in existence, and it's an option, you can use it, and obviously literature is available on how you're supposed to use it, etc. And just some aspects in terms of where it's so up to here it doesn't really make a difference on what the experience of the sexual activity is, in the sense, is it consensual or non-consensual. But even inclusion of EC pills in the guidelines for medical legal care for survivors of sexual assault and rape further evidences the fact that EC is considered as a required option in cases of consensual and non-consensual sexual intercourse. And I'll also just stop with, I was also looking at, where has this really been quoted anywhere by judges, and I saw that in one of the cases in the Guwahati High Court, where it was basically an appeal from a rape case, there was reference to the fact that while the medical of the rape survivor was done, EC pill was offered. So I thought that it was very interesting that as a matter of process, it's probably already happening. I don't know if someone else has already gathered that data, especially in the context of where it's a non-consensual sexual intercourse and resulting in the movement of the criminal justice system, or criminal legal system rather. But I found that very interesting, that it is pretty much there as a matter of fact, probably. And maybe we really need to look at that and consider how far is this being used, not only in a consensual setup but also in a non-consensual setup, and what is really what's really the outcome of that. I'm going to stop here if there are any questions. Thank you.
Thank you, Ms. Anubha. Excellent. You've reviewed all the legal issues and whatever is transpired, and I'm sure law will be supporting repositioning emergency contraception, because in last 10-12 years since we have introduced, it has made a dent on women's health. It has made dent in reducing the number of unsafe abortions. Definitely, there are some people very concerned that unmarried girls use it, but I still feel they use it is better than undergoing an MTP. So I think that way it is improving. It is giving us a lot of benefits. We can take up, if there are any questions, maybe we can first take up. I can see in the board there are 2 questions. There There is one question from Sunita Singhal. So what is the current legal challenge, or there is no challenge at the moment? So maybe this can be answered by Anubha only.
Sure. So, like I said, when I look at the law, there is actually no legal challenge to the
Yes.
existence and access to the EC pills. Like I said, that the contextual challenge really was more in terms of when the advertisements came up, and probably, I'm not, I'm not someone who's an expert on this, but probably it was just the, the flavor of the ads, and that may have been too forward at that stage. I do not know. But legally, like I said, there's nothing wrong. As long as the concern was with the advertisement, and as long as you're advertising as per law, that's fine. You can advertise. There is nothing which is saying that you can't sell it, or it can't be made available. Yeah.
If I may add, the challenge I think is in the expert committee recommendations, which say that it should be used only for an emergency, not as a regular method, and that therefore it places a restriction. So now we are talking of using it repeatedly in a kind of a planned manner. And I think that's where the challenge lies, not in the law, but how the law responds to an expert committee recommendation. Both the courts and the ministry have responded to that expert committee. Maybe that's where there is a challenge.
If I may just add, Dr. Iyengar, the expert committee recommendation is that when you're advertising, you let people know that this is not to be used, regularly, and it has to be used in emergency. Doesn't mean that it is stopping anyone from using it. It's only on the on how you advertise it. Don't advertise it as any other option of a contraceptive. And again, this was in 2009. Maybe one needs to also, push with the DTAP to maybe set up another expert committee if required, or just clarify this a little bit more in terms of where we are today, because this was something that in the context of 2009, when there were a lot of concerns with the ads that were coming up. Yeah, I'm going to stop here.
Right. You also pointed out that for non-consensual sex, in fact, when we initially started it, we worked in Delhi with Priyas and Delhi police, and we were sensitizing them that all rape victims, please give them emergency contraception as soon as possible. So we were even conducting trainings for them that they use this pill so that they can be protected from an unwanted pregnancy. And it will be good to make it easily available. And of course, now awareness is there, which was a big issue at that time, because people didn't know, but now it is being used. There are also some questions for Dr. Dharat, but he's already answered them in the box. So anybody wants to ask him anything? I think Dr. Chandramouli wanted his paper, which he has already said he will send it. He'll send it to Shilpa has also asked for it. So any other queries from any of these speakers?
Yes, and I think Dr. Bulbul Sood has pointed out that some changes will have to be made so that it can be used as a pericoital pill. And I think it goes back to what Anubha said about the need for the DTAP, perhaps to have one more expert committee.
Yes, very right. Because now what Mario has also shown us that pericoital use does work. So I think we need to really work more on those lines, and probably women will find it easier to remember to use it if they're using it pericoital every time rather than only for an emergency.
May I add something? For many years, people have used it as ECP, have called it ECP. And somehow there is some negative connotation because people don't like saying emergency. So I have always, maybe we should be going back to 1.5 LNG because that is actually what the drug is. And but if it becomes ECP, it becomes very different in terms of people have a hard time describing what is emergency. Whereas if it is 1.5 LNG, it's a drug at a certain dose. So maybe think about maybe in the promotion whether it's. I think it's better if it's described as 1.5 LNG. Thank you very much.
Thank you, Mario. I remember when we were trying to increase awareness, conducting training on emergency contraceptive, one of the secretaries had made a statement, which I don't forget. He said, Dr. Mittal, do we ever need to advertise for Viagra? People automatically buy it and use it. So I think our pill also has to reach that level that we don't need any advertising, we don't need anything, and maybe pericoital use would be a line in that direction. Then we will not have to say that it is emergency or it is this or that. Let them use it. And of course, Bulbul pointed out that we probably may need some more data in India. Yes, Bulbul, we can plan a good research on this line here. Yeah.
Thank you.
Thank you. Thank you.
Thank you, Dr. Mittal. I mean, this has really been an interesting session, you know, rounding off several aspects, the international scenario, the trials, the legal aspects, and of course, what has been happening over the years and the link to youth sexuality. We move to now the second session of the day, which is going to be a little more conversational, a little more informal. The session is going to be chaired by Mr. Anand Sinha, who is he's based in Delhi, and he's the South Asia Regional Advisor of the David and Lucille Packard Foundation, their reproductive health program. And with 28 years of experience prior to joining the Packard Foundation, Anand was with the Gates Foundation and led their primary healthcare initiative in partnership with the government of Bihar. And before that was with APT Associates as their country manager, overseeing private sector reproductive health initiatives in India. Anand is a familiar name, and I'll hand it over to you, Anand, for the second part of this interesting web meeting.
I'll just take 1 minute to thank all the 3 speakers of first session. They've done an excellent work. And also thank you, Sharad, for inviting me to join this important symposium.
Thank you, Doctor.
Yeah. Over to Dr. Anand.
Thank you so much, Dr. Mittal. Thank you so much, Sharad, for that introduction. Thank you for allowing me to join this amazingly important conversation. Thank you to all the presenters in the first panel. I think we've just learned a tremendous amount about sort of the history and where this product has come from and where the opportunities really lie. The panel that I'm coordinating and participating in is going to be talking about, well, somewhat a little bit forward-looking. Maybe you're trying to understand what the situation is right now. I have 4 speakers who will be talking sequentially. Let me start first of all with Gunjan. Gunjan is a professional social worker committed to empowering communities, particularly to women's sexual and reproductive health and rights. She's been associated with Action Research and Training for Health, ARTH, the organization that's hosting or co-hosting this meeting, based in Rajasthan, in North India. Gunjan is actively engaged in the research initiatives and community interventions aimed at advancing sexual reproductive health for women in these communities, which are largely tribal communities in South Rajasthan. Gunjan, you're going to be talking about some formative research and inquiry that you've been conducting as part of your work. Over to you, Gunjan.
Thank you, Mr. Sinha, for these kind words. Hello, everyone, and I'm excited to share some of the findings from our formative inquiry about women's experiences with single-dose LNG pill, which is commonly known as emergency pill. So we wanted to know what are women's experiences with this pill, but also what could be some of the circumstances that might lead women to opt for this method. So what we did, we conducted a qualitative inquiry in 2 districts of southern Rajasthan. And just to give you a brief, we are working with a population of more than 5 lakhs. And we have a network of, say, 486 women community health entrepreneurs who sell
think you have lost Gunjan for a while.
Gunjan, we're not able to hear you, and I think your video is frozen. If you're able to hear us, one option might be to try without video. Because I think most people are anyways looking at the slides. Okay. I think we have lost Gunjan. Sharad, is she in a location close to you?
Anand, she's joining from another laptop, another computer.
All right.
Computer just froze up on.
All right, let's just give it a minute then.
We may have to invite her. Can I ask the PFI people to invite Snehal Sinha? Irfan, if you can please include Snehal Sinha among the speakers.
Sure, just a moment.
Vivek, are you okay? Should we wait or should I?
Maybe we can move to the next speaker and then come back to Gunjan when she's ready.
Okay,
I think that's a good idea.
Yeah, because I think it might take her a minute to just log on and things, and I know we're already running a little bit late. So Vivek, if you're ready, I'd love to invite you to come and speak. Vivek Malhotra, I think everyone knows Vivek Malhotra. He doesn't need a big introduction. He's the CEO of Population Health Services India, is one of the pioneers of contraceptive social marketing in India, and has been involved in a large number of innovations and sort of leading edge strategies to look at increasing access to a wide variety of contraceptives across India and even beyond India. Under his leadership, HSI has become a leading social marketing organization in India. Vivek's going to be talking a little bit about the supply and the marketing scenario with respect to emergency contraception and the uses of that. Over to you, Vivek.
Thanks, Anand. Is my screen visible?
Yes. Yes, you're visible.
So I'm going to take you to a brief snapshot of what is the emergency contraceptive pill market size, slight history on what has happened and where the...
Vivek, are you sharing slides? Sorry, are you sharing slides?
Yes.
I can't see any slides. I just see you.
Okay. I was trying to... Not sure.
Okay, it's coming up. Great.
Is now my deck available?
Yeah.
So I will be very brief and very, run through this very quickly. We did a large scale study for the market size in 2019. The study was done post-COVID. At that point in time, we estimated the volume of the ECP market was around 33.5 million units per year and a value of roughly 311 crores. As you all know, ECP is only available in the commercial sector and it has a combined annual growth rate of 13%. There were two major players. The social marketing organizations were very small. ECP sales was seeing a slightly declining trend in metros. If you really go back to data of 15-16, around 48% sales of ECP used to come from the 4 metros, and rural segment was growing very fast. The key players at that point in time in the market were only two. One was Unwanted 72, which was having an 80% market share. The second was iPill, which was a pioneer, and their market share had declined to 18%. And there were other small players, mostly social marketing organizations, which had a negligible market share. I just want to stress the cost per pill. At that point, it was 99 for Unwanted 72 and 110. And this has significantly gone up by around 10 to 20% in now. It is a strange phenomena. These were the two players dominated the market. And these are the only two players who advertised this pill before a blanket ban on advertising came up. Social marketing organizations like PHSI, Janani, DKT, PSI had all tried their hand in ECP market, but they were not very successful. Then I just did this exercise recently for you. In 2020, which when we looked at 2019 data, the biggest markets for ECP were UP, West Bengal, Maharashtra, Haryana, and Punjab. And PHSI in the last 2 years have also, done fairly large volumes. We're now touching close to 5 lakh units a year. Our markets are slightly different: West Bengal, Northeast, Odisha, Rajasthan, and Telangana. What it actually showed was that ECP was being taken up across the board in various markets. Top markets were not in sync with category growth, and we were all other markets like poorer markets like Odisha, Telangana, West Bengal were also similarly started using emergency contraceptives. I have one more point to say, actually, from my previous slide. If you really compare ECP and OCP, around 80% of OCP market volumes come from second generation OCP, and they are commercially or even social marketing. All of them are priced below the ECP. Consumer prices are up to a maximum of 70, where ECPs are priced over 100. That was all on the market size. Any questions? Happy to take.
Thank you so much, Sharad. We'll come back to questions from the audience at the end of all presentations. But at this point, I think this was really helpful just to get the snapshot of what's happening in the market. And basically what I'm taking away from it is that there are two very large players who seem to be dominating the market, and the price doesn't follow a very strong rationale. Gunjan, are you back? Sorry, we lost you there for a minute. If you're back, do you want to pull up your slides again?
Just a second. Yes. Can you see my slides?
Not yet.
Okay. Can you see my slides now?
Not yet. Still not visible yet.
Is it not?
Use the PDF.
Yes, just.
Yes.
Yes. Now they're visible.
Yes, so I was saying, so we have a network of say around 486 women community health entrepreneurs who are trained, and they sell commodities including pregnancy tests, oral pills, condoms, and single dose LNG pill, which we have renamed as Turantpuli. So none of these community health entrepreneurs maintain data or records of their purchases, and neither do we ask them for any details. So for this study, what we did, we selected villages which has highest uptake of the single dose LNG pills by community health entrepreneurs. We visited that villages. We asked women. We met community health entrepreneurs, and then from a random start, we went to house and talked to women. We took consent and started asking them about their menstrual hygiene practices. If there was privacy, then we asked them about their contraceptive use and use of single-dose LNG pill, if any. In this process, we talked to around 39 women, of which 4 of them were just not, they did not give the consent to talk about their experiences, so we just dropped it. So we have the story of around 35 women. This is methodology part, which I'll not go in details. Just to let you know that we did to consent from the participants, and all the transcripts of the interviews were anonymized. Now I'll talk briefly about this conceptual framework. So we looked at women's personal circumstances as infrequent sex or sudden or unanticipated sex. Now the question was, what would women response would be to such encounters? And here we looked at, okay, there would be some factors that might influence how women would respond to such encounters, which would include prior use of contraception, her autonomy, the stigma, and other determinants that you can see. And then what would be the response? So either the women might use contraception such as condoms or withdrawal method, or at a later stage might opt for abortion. In other case, she might not use any contraception, so there will be no response. And the third one would be use of single dose LNG pill. And here comes the experience part, that will women procure it before the act or after the act, and how convenient would be afforded, the cost aspect to it, and will be and how what will be the outcome of the pill. So this is what our findings are. So we talked to around 35 women, of which 19 had used single dose LNG pill. 7 of them had used it more than once. Now, among those who are repeat users, most of them were these community health entrepreneurs themselves. Now, this could be also because they had easy access to these pills, and also it was much cheaper for them to buy it. Apart from these community health entrepreneurs, it seems that the women who use these pills, the dominant pattern was taking the pill after the act. So as I said, we talked to 35 women. 1 was engaged and the rest were married. 12 of them had abortion before. Most of these women belong to socioeconomically marginalized scheduled tribes and scheduled caste. Significant proportion of women were functionally illiterate. We also looked at migration status of husband. So many of the women had migrant husband. Just to note, here we are defining migrant as someone who lives away from the home, and there is a regular separation for spouses. So how long does the partner stay? So it seems that the husband stays for a week or so, and he comes at least once in a quarter, it seems, from the women's experience. So here are the qualitative experiences of these women. So we looked at infrequent sex. So majority of women said that partners' travel or migration was one of the reasons for infrequent sex. Also, some expressed that they don't feel the need to use the contraception because the partner is not at home. Interestingly, some non-migrants also reported infrequent sex, just to wish to avoid pregnancy. Duration of husband's stay influences how women use contraception. So one of the women shared how she switched in between contraception according to her husband's stay. So for example, if he's going to be there for a day or two, she might opt for Turant Goli, which is single dose LNG pill. And if he's going to be there for a month or so, she'll start using Maladi, which is a daily oral contraceptive pill. So here are women who are, this also indicates how women adapt to using contraception according to their need and their preferences. Few women reported that they were aware about their partner's coming. So they also know how long he's going to be there, so that she can plan which contraception to use. And there were, of course, some women who were not sure about their husband's arrival, which brings a lot of anxiety along with low preparedness. As a response, some women shared that they use single-dose LNG pill because there was break in their regular contraception. So one of the women said that she forgot to take Maladi, so she had to bought this single-dose LNG pill from the community health entrepreneurs. Another shared that because she was using condom but it broke, so she had to take the pill. And there were few women who, despite knowing that their partner is coming, they still had a lot of anxiety, and so they stocked up on more than 2 options. So, for example, a woman says, and I quote, "Thoda dar to lage hi hai. I always keep emergency pill and condoms with me." There were few women who relied on natural methods as well. So that includes using withdrawal method, using safe period method, and also avoiding sex. And here's what women's experience with single-dose LNG pill look like. So many of the women preferred the single-dose LNG pill over other contraceptive, especially with daily oral contraceptive, because of its convenience of not having to take the pill daily. Another also report, some women also shared that they find it suitable. Suitable for infrequent sex. One of the women says that okay, हमारे कभी कभार ही बोलचाल होता है, like we have sex once in a while, so just take the pill and you don't have to worry about getting pregnant. And then there were some women who use these pills repeatedly, and one of the major reasons for repeat use of this pill was non-availability of other options at that time. There were few users who shared their initial apprehensions and their doubt about efficacy of this pill in terms of how can we be so sure of only one pill. So, and then after their successful, after what they expected from the outcome of the pill, they started trusting it. In this case, her periods came, so she was sure that she's not pregnant. Among these 19 users, only one user reported abdominal pain as a side effect, which was of course not welcome from her side, and then she switched to some other method. Interestingly, one advantage that emerged from this discussion was cost effectiveness of this single-dose LNG pill. One of the women shared her previous experience with abortion, and it compared with the cost of single-dose LNG pill and found that this pill is much cheaper. Here's a woman who is working as a community health entrepreneur. So she herself gets the pill at around 20 rupees, which is much cheaper. And as we mentioned earlier, there were 12 women who had prior experience of abortion. Now, it appears that women look at daily pill, emergency pill, and abortion pill as a continuum for preventing pregnancies. Of those who have prior experience of abortion, it seems some of them have started using the single-dose LNG pill, while some shifted to combination of oral pills and condoms. Now, we are not sure if this abortion pill use has triggered the use of single-dose LNG pill, but it appears that women are quite positive about using contraception. So what do we learn? What have we learned from this formative inquiry? One is that it seems that there is close association among use of single-dose LNG pill with awareness and access to this method. Those who have access to it, it seems that they'll use it more often and sometimes repeatedly. In this case, community health entrepreneurs. For some women, it was a low-cost option. There were women with migrant husband. In order to prevent pregnancy, they navigated their own journey of using contraception, sometimes in combination, which includes avoiding sex, using condoms or single-dose LNG pill, and daily pills. There were migrant couples and those who have infrequent sex. It seems that they are using single-dose LNG pill. We also found that men are more willing to use condoms, especially in this case with a migrant couple. And it might make a sense to, actually promote a combination of condoms as well as single-dose LNG pill as a pericoital contraceptive. And in this study, we actually did not find a stigma among users of the single-dose LNG pill, but it's worth to mention that these pills were promoted and provided as Turant Goli, which is like a quick pill, and not just emergency pills. Lastly, this is what we have found, but we need to know more about so that women in our communities and similar communities can make better use of an option which is which has long been neglected. So.
Thank you so much, Gunjan, for those insights. And I think, again, it tells us a lot about the potential and how this is being used in on the ground and in real lives. Our next speaker is Vitika. Vitika Yadav is a human rights activist and social entrepreneur who's known for her work in the domain of sexual reproductive health and rights, human trafficking, gender rights, and the future of education. She's widely recognized, and I know her most well from her work at being the founder of Love Matters India and establishing one of India's most leading digital platforms that advocates sexual reproductive health and rights and gender and sexual orientation. She's also helped set up Teen Book in India, which offers comprehensive sexual education, both for adolescents, parents, and educators. She's also the chair of the Global Advisory Board on Sexual Health and Well-Being. Vitika, great to see you. Over to you.
Thank you, Anand. I think, this has been really interesting because a lot has been shared in terms of research, legality, in terms of the implications, how emergency contraception pill is being seen in the market and over the years. But when it comes to any kind of communication around emergency contraception, and for that matter, I think any kind of contraceptive choice through any medium or channel, the most important thing is to recognize that decisions surrounding reproductive health are deeply personal. And the communication around emergency contraceptives, in particular in India, has, I believe, experienced a blend of progressive and regressive elements. And this is where, all kinds of channels also come in play. There is obviously more visibility when it comes to television and that kind of media, but also things have shifted a lot with the advent of social media and digital media. And the communication via not just advertisers, but also via doctors who are also operating in the online space now. And, how social media influencers, who are also representative of the population at times, they are also involved in designing the communication around emergency contraceptive pills. So the whole advent of digital media, I believe, has also played a very, very important role in disseminating information, along with, of course, the educational resources and websites and all of that. But one thing that we can certainly say that the communication, there's broader access to information, and that is especially, among the urban population and younger demographics. But the information is out there. There is also enough research that has been cited that talks about the fact that encouraging information and education about any kind of contraceptive method, and including emergency contraceptive pills, it empowers individuals to just take informed decisions about their reproductive health. It's interesting that the emergency contraceptive pills has been more controversial than other contraceptive methods, and the fact that it is about providing options information rather than dictating morality, which has largely been linked to emergency contraception. We also know that utilizing the ECPs, is a responsible decision in situations where regular contraceptive methods probably fail, or in case of just unprotected intercourse. And, if only we could plan so many things in our lives. The truth is that not everything in our life is planned, and it is about taking proactive steps to prevent an unintended pregnancy, which is not about promoting unprotected sex. Now, of course, like when we talk of, the kind of the way the communication has developed, has been passed on to people, there has been an increase in awareness campaigns, and it has been supported by both government and non-government organizations. It has been aimed at educating people about emergency contraception. but the interesting thing is, how we can probably look at reframing the notion of emergency, and the terminology, because the term emergency in itself, I think, which is attached to contraception, has probably contributed to more stigma and misconceptions surrounding its use. So one of the things that probably we need to think of is it, if you want to move away from from the way emergency contraception, the ECPs are looked at, towards normalizing it, it is important to probably think of doing away with the word emergency, and how to shift from stigmatizing to normalizing it as a vital aspect of reproductive health. Now, the term emergency in itself, obviously, it inherently implies a crisis or an urgent situation, and when we throw away terminologies, we don't really think about the implications it might just have. But something that is a natural and spontaneous aspect of reproductive health, we are labeling the way it is being labeled, it often leads to judgment, moral scrutiny, and sometimes unnecessary shame. And in this case, the fact that ECPs are linked to irresponsible sexual behavior and all of that. So the emphasis on emergency contraception also places undue burden and responsibility on women, and actually largely on women, because it's perpetuating that notion that contraception is solely their responsibility. It is not a shared responsibility when we look at it from the perspective of a healthy relationship. I will not just look at it from the perspective of family planning. I would look at it from the perspective of healthy relationship, which actually should be the focus of most of our communication around contraception, and around healthy sexual behavior and safe sexual behavior, because young people are not having sex just to plan families or not to plan families. And if we can turn the communication around what makes for a healthy relationship, then we also need to look at how do we destigmatize language around some of these contraceptive options. I think removing the word emergency in terms of communication around ECPs will also allow for acknowledgement that there are unplanned scenarios, and it's a normal part of our lives and our reproductive health. And let's not believe that all sexual encounters are always planned. It does not happen. So if we are trying to sort of not live in some kind of disbelief, I don't think in terms of how we are looking at choices in reproductive health, we're doing the right thing. We need to acknowledge there are all kinds of situations, and there are unplanned situations, and how do we just normalize a contraceptive choice that is available and should be seen as one of the options available when it comes to the basket of choices. So also the idea is to create an environment where seeking contraception is not stigmatized, but it is seen as a responsible choice. Just the fact that someone is making that choice, knowing that there is a basket of choices, is also to be respected. And for women to feel empowered that taking a decision about their own health without any societal pressure or without any fear of judgment is hugely empowering. So I think just from the perspective of communication, I think the first thing that needs to be done in terms of normalizing is, can we just do away with the word emergency in itself? And probably communication should highlight scenarios where the ECPs can serve as a backup contraceptive. I mean, of course, it is seen as a backup contraceptive option, but not just for emergencies, but as a part of proactive healthy sexual life or proactive family planning. I think that's where the communication really needs to shift. Interestingly, we see a mix of both on social media platforms. I did a recent research in different countries where there is a very interesting trend around social media as well, where there is a lot of focus that young people are making on doctors and doctors' advice on social media. And with all the communication that is out there, we know that there is a lot of judgment that is loaded in different doctors and different practitioners, health providers, and the advice that is being given out. So it's also interesting that when it comes to communication and messaging, it is extremely confusing for people because they're getting it from everywhere. They are overburdened with the kind of information that is coming to them, and who to trust and who not to trust, and who is really an influencer for them, or who would be the right kind of an influencer for them. That's a question as well that we need to deal with, I think, as we are designing communication, because there is everybody has their own approach around ECPs, and there is a real fear-based approach around ECPs, which isn't helpful. There are concerns and there are concerns around side effects, which are there, but just emphasizing clear and transparent communication regarding the potential side effects without inducing unnecessary fear and stigma is extremely important. Now, how do you provide that kind of balance? Is there a kind of checklist, around ECPs, that in terms of communication around ECPs, that could be that could be centralized in a way that from practitioners to social media influencers to pharmacists, everybody would be speaking the same language? It is hard, but probably what is needed is not to confuse people, but to sort of really make sure that they are able to access and use contraceptive pills without any fear and without any stigma and without any judgment and morality. And that balanced information should acknowledge that there are possible side effects, but also recognizing their transient nature and rarity, because ensuring that people are informed. They are not intimidated, but they're informed. So the idea is not to keep information away from them. Of course, there are side effects, but the truth is also that you have to look at the numbers. You also have to look at the fact that every body is different. So something that works for one might not work for someone else. So what is likely more good than, is what is the perspective that they can carry in terms of taking an informed decision? So that cannot be fear-based. That has to be information-based. And I think in terms of communication, that is extremely, extremely important. In essence, I think the use of ECPs is a pragmatic and responsible measure, and we are seeing that from research. It is allowing women, it is allowing individuals to take control of their reproductive choices, and it is important to shift that narrative from the moral implications and focus on providing more access to information and access and support, and keep it real. I think there is one thing that I'm constantly learning from young people, and when you speak to them, is that don't give us information which is like, oh, life is going to be perfect after this. Keep it real. There are all kinds of scenarios, and all of those scenarios are real scenarios, and that's what makes it authentic actually for them. That is what makes it relatable for them. So relatability in terms of communication around around ECPs, and for that matter around all the contraceptive choices, is missing in many ways. And I think that is being articulated by young people. So that's something for us to really think about in terms of communication. And yeah, I mean, I think it is important in terms of informed decision making rather than being intimidated. So communication really has to be centered around that. Thank you.
Thank you so much. I think those are such important points about, I mean, I guess one of the key things I'm hearing is just taking away how do you sort of separate the ethics and the morality sort of that overshadows the actual practicality of what we're dealing with. Thanks so much. We'll come back for questions in a bit. The final speaker on this panel is Sharath. Dr. Sharath Iyengar is a pediatrician, public health professional, began his career doing research in communities on maternal child health and family planning with PGI Chandigarh, went on to a career at UNFPA in India for many years, and then established ARTH in 1997, based out of Rajasthan. Since then, he has managed this amazing spans of work, which includes deep level community engagement, implementing programs and research and advice, and working on boards at many levels. He's a teacher, he's a researcher, he's an advisor to WHO and many organizations such as that. Sharath, over to you, and we're going to be talking about reducing stigma. So I'm really interested to hear what you're going to say.
Thank you, Anand, and thank you, Vitika, for laying the ground. I realize that we are a little short on time, so I'm going to, come to the very specific points that I wish to share. Stigma has been, defined as a mark of disgrace related to a certain circumstance, an event, an action, or even a person. In the context of emergency contraception, there seems to be something disgraceful on part of a woman to be using emergency contraception, especially if she has to keep on using it, use it repeatedly. Now, I am personally rather surprised that, how with many emergencies occurring in the field of medicine and health, you have a contraceptive that's labeled as an emergency method. In a way, even the condom has to be used when someone is having sex, so it's an emergency condom. But we don't call it that. I mean, if you have a severe headache, you take a painkiller, that's also an emergency product. The labeling of emergency with a contraceptive begs the question, what is the emergency? Is having sex an emergency, or is contraception the emergency? And this seems to be some kind of a crisis or a problematic situation that a woman gets herself into. Now, at this point, I want to exclude the issue of rape, which is a real emergency. It is non-consensual sex. And the response to rape has to do a lot more than just, prevent a pregnancy. So acknowledging that, let's look at the large mass of consensual sexual relations, which Kritika has touched on. Sex happens. It's a spontaneous act. There's excitement in it being a bit unplanned and spontaneous and, occurring at different times and places without any scheduling. And so, to go around assuming that sex is going to occur according to a certain pattern when a woman is ready or the man is ready is, being a little short-sighted. And yet, to some extent, it appears that people get themselves into trouble rather than that being the very nature of sexual activity. Now, if a woman were to use a contraceptive when she's not having more sex, and in the case of, say, a daily oral pill, the contraceptive might be taken more frequently than even sexual activity. It might just denote to her partner or partners or others around a certain readiness for sex and could impute promiscuity. And women, therefore, all around the world, and including in India, tend to avoid being seen as taking care of a possible pregnancy when sex is not on the immediate horizon. There have been studies and commentaries on this in the UK, which is a unique country where it is an over-the-counter product, but it needs a consultation with the pharmacist. So you've got to have a chat with the person selling you an emergency contraceptive pill. Thankfully, that's not so in India. And what commentators have said is that the use of ECPs denotes a certain irresponsible sexuality. That this woman sleeps around, and therefore it should be regulated in order to avoid misuse. And if you see the language of the DTAB minutes, which Anubha referred to, there's a lot of this about being the need for regulation, the need for seeing that it's not misused, and so that it does not lead to, open and free sexual activity. In some ways, in the minds of some, it is also seen as an abortion. Now, we all know that medically and from a scientific viewpoint, there isn't a conception, so there's no question of abortion. However, in the lay mind, here is the termination or the prevention of the possibility of pregnancy. It is done after the sexual act, which could lead to pregnancy. And here's something done to prevent a pregnancy. So in the minds of some of the users, this somehow is seen as being equivalent to abortion. And therefore, merely going around ad nauseum saying this is not abortion may not work. Now, if the use of the contraceptive is in the time of a crisis, clearly it should not be repeated. The WHO's medical eligibility criteria, show that repeat use of EC pills is categorized as level 1, which means there should be no restrictions on repeat use. However, you find the language around the regulation and the policies and the advice from providers being one of, be careful. This is something not to be used very often. And so there is a perception created that this is a risky product. The attention then goes to side effects and their magnitude and their, gravity. Another feature of the emergency pill, and Vivek touched upon that, is that they're rather expensive. At least in the West, the price is high because pharma companies apparently believe that if you bring down the price, there will be wanton use of this product. And strangely, even in India, you find that the emergency pill is not just far more expensive than the old generation of oral contraceptive pill, but even the new generation. The price currently ranges from 100 to 120 for a single pill. Now, initially, when the emergency pill came on the market, you used to get 10 pills in a pack. This is what Boots apparently came out with. And these were 0.75 milligrams, so they had to take 2. So this was 5 doses on one blister pack. That was later reduced to a 2-dose pack. And then now we have only a single dose pack. So somehow the industry has made it difficult for women to take it repeatedly. Prices have gone up and the packing has come down. Ultimately, what is being done is that it's being shown not as a choice for women, but as a need if they are in a crisis. So it is seen more as something, a contraceptive of last resort. So you don't go around thinking, planning, and taking it of your own accord. Ultimately, I realize if a woman's life is such that sex is irregular, how do you expect her to use a regular contraceptive? Sex is infrequent. Why do we expect her to use a frequent contraceptive? So it was in response to some of these things that we have made a small attempt. I'm just going to share a few slides of what we have tried to do with this idea. Just give me a moment. Just give me.
Do you want me to share the presentation?
Yeah. Oh, wait, I've got it. I've got it. Can you see my screen now?
Yes, yes, we can.
So essentially, when we introduced the single dose LNG pill in rural tribal southern Rajasthan, as Gunjan mentioned earlier, we first called it the sudden pill, the Achanak Goli, but we found that calling it the sudden pill was a bit negative. I mean, what do you mean by a sudden pill? It should be seen as a solution. And therefore, we changed the name to Turant Goli or the quick pill. And the messaging has been that if your husband has come home unannounced and, naturally, you meet, wish to avoid a pregnancy but have not used a contraceptive till that point, take a quick pill within 3 days. We have also produced an informational brochure, which is a kind of an FAQ, what is this, how does it work, and does it cause side effects, and so on and so forth. And later on, in the last 2 years, we've realized that we can probably visualize two scenarios. One is couple, young or old, there is spontaneous sexual activity occurring without planning, without scheduling, and without a contraceptive being used before. So if sex happens suddenly, and the word in Hindi, I wish to point out Achanak, it's not the same as sudden. I don't have a very good translation. Achanak doesn't have those, ominous connotations that the word sudden has. Sudden is a bit negative in its connotation, whereas Achanak is, happens without planning. So if there is an Achanak Milan, then the Turant Goli can be used and it works for a day. And there is a disclaimer saying that if the woman is already pregnant, then, it doesn't help. Second scenario is that of infrequent sex. So if there's a migrant husband who arrives, kabhi kabar bolchal. Bolchal is a common term used in our part of India. It's a very interesting and a nice term, I think. And so in case of infrequent sex, you can use the Turant Goli, and after consumption, it works for a day, implying that whether you have one or two or more sexual acts, so long as it's 24 hours, it doesn't matter. And we got worried about what about all these regulations on advertising, which say that you should only position it as an emergency method. And we've tried to say that if you have sex without tayari or without preparation, advanced preparation, then you can use this pill, implying that ultimately, what is the emergency? It's that you had sex without preparing, without tayari or without prior advance precaution in the form of a contraceptive. And so, whether the couple is migrant or otherwise, they could use it. It is a small attempt, and we just hope to see. The moot point is it's been brought out by participants and those attending this webinar that we need a better formulation than just calling this an emergency method, or at least we need to remove the alarm, the fear, the sense of crisis, and the sense of avoidability that emergency brings. That looks like the root of a lot of the stigmatization. Now, while in our grounded study, we didn't find it, but I must, Kunjan mentioned that women were responding to this Turant Goli messaging. We do know that doctors, providers, and others have this alarmist view of emergency contraception, and maybe that's a place. Anand, you mute. Now we can hear you.
Hi, can you hear me?
Yes.
Great. Thank you so much for that, Sharad. I think again, very and I think the examples you're showing are great ideas about how one can go about trying to sort of address the stigma that the product has been sort of wrapped up in. There are a couple of questions. If I don't know if but I know we're over time. I think Leela had a question about is there evidence of how ASHAs report their advice on EC pill or acceptance? Is there data on its failure if taken later than the time of effectiveness? We could use this for awareness building. I'm not sure if there is data. Probably.
I have no idea how they report it. They note down names, for example. Anand can't hear you.
Rashmi has talked about, again, I think just agreeing about the fact of how it's positioned as an emergency paradigm. I think Bulbul made an important point about how many doctors are concerned about the issues about bleeding, prolonged bleeding as a result, and that's often something that hasn't been really considered as a serious issue, as a serious hurdle, and that seems to be what from the data that Mario was presenting seems to be the case. But that was interesting. Thank you so much, panelists. I'm going to hand it back to Sharad or to Poonam. I'm not sure. Who do I hand it back to?
The last session is essentially a look at the way forward with Poonam anchoring. Poonam, over to you, Executive Director of the Population Foundation of India, and someone who is a little bit too well known for me to introduce.
Stop embarrassing me. That's, there's a introduction. I know that everyone says don't need introduction, but this is embarrassing. But however, Sharad, thank you very much. And thanks. It was Sharad's idea to have this meeting, and we jumped at it because apart from our work on on issues of choice for contraception and behavior change and so on, we were very excited because we also are experimenting in 6 districts of UP where we are working apart from with using other choices. We are working on using emergency contraceptives with ECPs with the community we are going to work with. So may I, Sharad, just capture what we are trying to do here, what I understood after quietly listening, happily listening and learning for 2 hours. And that is that our goal is to support what we are here to do. What I heard is supporting women to use emergency contraceptives, pills, ECPs, both as a backup and a regular on-demand contraceptive method. Is that fair to capture? We can increase the self-managed, promote it as a self-managed contraceptive option while enhancing the reproductive autonomy and informed decision-making. Some of the quickly I'll flag, and then when Sunita and Anand come on, they can help us find solutions to who will do what. So clearly rebranding, if I may use the word, there's enough rationale, reason, not only what we heard at the end from Dr. Iyengar and also from Vithika, but there is alarm, there is fear, there's crisis, there's also stress along with the fact that women is in crisis is so unnecessary for her mental health and giving additional stress. So how do we work? Who takes the responsibility of doing the advocacy and working on rebranding nationally, as well as, I would say, regionally? If we can't do it nationally, let's do it at least in different states and begin. We have to work on greater information sharing, behavior change, remove the doubts regarding the efficacy of the pill, and pricing is a huge issue. You know, I mean, maybe we need to do the cost calculation and share with government on the, using a ECP versus going through an abortion or having an unwanted child. Finally, we do need to work with members of parliament. It was the alarm in parliament on the advertisements of the advertisements that led to the ban on advertising, and also behavior change communication. And what came out clearly is we need to do behavior change communication on broad set of issues, normalizing sex. I like, Ritika, you mentioned stigmatizing to normalizing. Normalizing not just ECP, but normalizing sex. It is very natural for Ritika to say that, given the past history of her work, and I love the name of your organization. It's so appropriate here, Sex Matters, right? So with that, I hand over to you, Anand, and then to Dr. Sunita Mittal, and let's plan for the way forward. So what will you fund? Who will you fund? We'll list out. Sorry to put you on a spot, Anand.
I knew that's why you'd put me in this like way forward. Like, what does Anand know about this in any case? The only thing he can do is fund it, right? So, Dr. Mittal, however, knows a lot. So I know she's going to give us a lot of advice. Okay, so as a layperson, looking at this, and as someone, and I'll tell you, every time I think about ECs and emergency contraception, I keep on thinking about what has happened in India in the last 10 years with respect to medication abortion. And one of the things that does make me always feel about medication abortion is none of us had a hand in the trajectory and the tremendous growth of this product. It was essentially consumers exercising, their own choices, their own demands, and a set of manufacturers and a set of marketers who were able to make the product available, and it just took off, right? No one had to go around doing a huge amount of education and repositioning and all of these things, right? So what is it that has locked emergency contraceptives into a box? And I think everyone's right. Calling it emergency contraceptives has somehow locked this contraceptive in this glass box that someone needs to come with a hammer and open it and take it out. And so in our minds, we have put it away, right? Now, how do we kind of release this product from this box? I mean, is a way that I think I have been thinking about the challenge here. The product is available, the price is high, but the price is not what has led to the situation there. Is it that people, the awareness of the product is low? Yes, probably it is. A lot of the data that Gunjan showed, it seems that, once people are aware of it, once it's easily accessible, they take to it. They take to it quite easily. Is there a need for a lot more clinical evidence? I don't know. From what Mario was presenting, it seemed like the evidence is pretty, is pretty substantive to say that as a pericoital method, if we're going to compare it to what's its nearest neighbor, a condom, perhaps a diaphragm, it's in that ballpark. It's not the 99% effective gold standard contraceptive method, but it's in the ballpark of the methods that we should be looking at, right? So it feels like it's not going to be a ton of clinical sort of research that's going to actually unlock and unleash the value of this product. I think the other thing, just to go back to, and I remember this with some research that Niranjan from Population Council was doing, especially for Bihar and UP, was, he said that in the most recent NFHS surveys, again and again, we're seeing that the most common reason for not using contraceptives is infrequent sex. there are more and more couples. So this idea of infrequent sex being something that is only there for migrants, or only there because you're unmarried, or only, a very sort of niche thing, it's not really, it doesn't seem to be the norm. I mean, the norm is actually that, infrequent sex is being reported by, a largest percentage of people who are saying that they're not using contraceptives regularly because they don't feel the equivalency, or the equivalency in our minds is that only if I have frequent sex do I need to think about contraception. Otherwise, what's the point of it, right? And so we don't seem to have a method mix that deals with this, this need. And obviously, LNG 1.5 is one of those products that can fit in there very easily. I guess, and one of the questions that, and I think, Bulbul sort of, lit that point well, was in one of her questions, was the fact that, we have, I think from what Mario was saying, is that it leads, it on average is about 10 to or 16 days of bleeding as a result of use. Now, and again, one of the things I'd like to understand is, what does that mean for infrequent sex? Even if you don't have infrequent sex, you will be forced to have infrequent sex because you're bleeding half the month every time you take one of these, every time you take the product. Is that what it leads to? And I'm not sure, I'm not a doctor, but that's sort of one of the big questions in my mind, is how well have we understood? Because as much as we try and equate it to saying, are we trying to now provide women with the condom, right? Because it's something that I have in my back pocket, I can use it and it enables me. And I think that's the empowerment sort of perspective of what LNG 1.5 could be all about, is that it is a process of empowering women to really take choices and decisions into their hands. You're not forcing them to say, you need to think about this a month before, or you need to think about this.
I'm going to interrupt you because we are, the time is over at this point of time, but we have the group. No, I'm not, I'm interrupting you. I'm not stopping you.
No.
I just, we have to talk about the way forward, and literally let's make a plan on who will take what responsibility. Maybe we won't be able to do that, but let's identify the 5 things that need to be done in the short run and long run. And we are counting on you and Dr. Mittal to tell us. I also know we have a brilliant audience here who have stayed the course, stayed with us. We also have the privilege of having Rani Bang with us. So we hope we can, I'm really hoping we can go back to the conversation on planning and working collectively, but let's at least identify which are the areas we need to move forward on. Isn't that what you wanted to achieve, Sharath?
Very much so.
So, Anand, I really like your concern for infrequent sex and so on, but on another day.
I mean, I think there's 2 or 3. One is that, there's a lot of questions about the policy space. So we need to understand what is the policy barriers that actually exist. Okay. And I think we also need to do it in a smart way, that we don't go and there are ways when you can go and put yourself behind a policy hurdle, and there are ways that people just walk past the policy hurdle, right? And we've seen that happen many, many times. So the question is, do we want to go and put ourselves behind a policy hurdle, or do we recognize that consumers and clients will figure out how to walk past the policy hurdle? What do those look like? And do a realistic assessment and not an academic assessment. I think Anubha has really helped us sort of ask those questions. A lot of what we're putting ourselves behind saying is, oh my God, we can't talk about this, we can't advertise, we can't sell. And she's telling us, I think fairly clearly, no, there is no such thing. Okay, we're just working in this environment and have allowed ourselves to do that. So we need that realistic assessment. And I think the second one that I'm talking about is really getting a very, very keen understanding of clients from a user perspective, right? About how would they interact with this as a method if it were really positioned as a pericoital method and not as an emergency contraceptive method, because it's still being provided in that frame. I think the work that Sharath has done is clearly, is clearly a way forward in terms of saying, I'm now calling this a Turant Goli. Now what do you do with it, right? Versus calling it an emergency contraceptive and saying, what do you do with it? Once you position it in that emergency contraceptive box, you're putting it out of reach. of most people. So we need to do some research around that. I would say that those are probably the two big immediate steps.
Great, thank you, Anand. And Dr. Mittal.
Thank you, Poonam. I think listening to everybody's presentation over a couple of hours, something which is coming to my mind, as you said, solid points. First thing, people who have presented actually work in the field. I only work in my clinic, but they have the field experience. And I gather from that world emergency definitely needs to go. We need to rename it. Mario has presented his research. There are other publications also on pericoital use of levonorgestrel. However, we still, Purvul also suggested, in India, we haven't done much research on pericoital use so far. Besides, I'm not very sure how the public will react to word coital. So, if we really can call it either a backup method or something, Turant Goli can also go. I don't see any harm in that. Emergency word should go. And when we are talking of pill, Turant Goli is a good nomenclature, or a backup pill, whatever. Because I have seen this, when we propagated it, it was called ECP or EC pill by government. But its popularity only was rising when it was being marketed as IP. Women were not shy of telling their friends, I have taken an IP, you also use it, it's very good. Though I made no sense, it was only company marketing that IP. But IP name gained more popularity than ECP at that time. And of course, for emergency, we have other things, intrauterine devices and all. So I think if we are working on it, let's work on removing the word emergency. At that time, when we were introducing, it was probably very relevant, but at the moment, it sounds irrelevant after hearing everybody's perception. And the second suggestion, of course, let's do some local research in our country on pericoital uses. It should not be very difficult if there is some funding available. We could organize, have a protocol and do, so that we could popularize that. That is another thing. Yes, as he's saying, lack of preparation. It may be preparation, it may be condom use and a failure, and then you are using it as a backup. So don't say it's always an emergency in that sense. So maybe a backup pill or a Turant. Maybe two we can consider depending on the type of population we are dealing with. That would be one suggestion, and of course, little more research on this pericoital use, which would go a long way if we can have that.
Thank you. We have we've identified the key areas to work on, and now we have to volunteer, we have to strategize. And I hear you, Anand, you're saying we have to be careful, tactical, and smart, strategic. Turant Goli is a great name. We can all put our weight behind it. I would. And politically, it's a smart thing to do because the current government wants Hindi everywhere. And this is recommendation from a South Indian. The rest of your states may not accept it, but we take it as a good recommendation coming from a South Indian. So rename, rebrand, look at and articulate the barriers, and we think and have faith in, the politics. They're all saying have faith in the voters. So you're saying have faith in the demand, the markets, and demand will shape the prices and other things. And finally, but there is a need for behavior change communication, including of the provider, and there is a need for shaping demand still. We need to reach information. And I had a question from Vivek, why did the CMOs fail? But I'm not asking this question, but it's very important to reflect on that, and we learn a lot. And so 3 cheers, Sharad. I think your work and your wanting to put this in this important space has really worked and onwards is what I would say we'll have to plan going forward. Thank you, everybody.
Thank you very much, all. I mean, time doesn't permit an even longer discussion, but I think we have gone beyond by about a half hour with, of course, the technical glitches that almost seem to be inevitable. But nevertheless, we have held a large audience for a long time. And I think clearly this is the first step. We need to go beyond, do something more, and then we'll be reaching out to you to take this ahead, perhaps form a small working group and keep thinking and working on this. The idea was not to just meet over a web meeting and then say our things and listen to each other, but it was to trigger something, and therefore we called it exploratory consultation. Thank you very much, Poonam, Anand, Dr. Sunita Mittal, Dr. Darak. Dr. Mario Festin has left. It was late in the evening and Christmas celebrations have begun out there. Thank you, Gunjan. Thank you, Vitika. Thank you, Vivek. A very different perspectives coming in. Clearly, it adds to the richness of the discussion. What is really seems to be a very low tech, a very simple thing. People don't even seem to be interested in something that women will pop on their own and get from a chemist directly, and yet it looks so complex. So let's try to find a way forward. Thank you very much, and greetings for the upcoming holiday season. Thank you very much.
Thank you all.
Thank you.
Thanks, everyone.
Thank you.